Thank you very much. You got it right the second time. Farrugia. It's a pleasure to be here today. I'll present the first case. It's an iliofemoral case. These are my brief disclosures. So we have a 78-year-old male with a history of coronary disease. He's had a 3-vessel bypass in 2016, hypertension, hyperlipidemia, former tobacco abuser with a very long history of peripheral arterial disease, who came in through the emergency room with complaints of severe worsening of right foot, numbness and coolness in his toes at rest, with worsening calf pain walking 5 to 10 feet. The patient was noted to have a slight pallor of the right foot compared with his left. He stated that his symptoms started approximately a month prior to admission, with calf pain walking down to his driveway to the mailbox, and has gotten progressively worse over that time. As stated, his past medical history includes coronary disease with a 3-vessel bypass, hypertension, hyperlipidemia, and extensive peripheral arterial disease, including a bilateral FEMPOP bypass performed in '92 and bilateral iliac artery stenting performed in 2015. Former smoker, 2 packs a day for 30 years. Nothing exciting on his medication list. He's on dual antiplatelet therapy along with a statin, ACE inhibitor, and a beta blocker. No significant family history. So the meat of this is really his exam. His vitals were completely stable. Cardiac exam was normal. When you start talking about his extremities, that's where it gets exciting. So he had normal radial pulses. On the right side, his common femoral was faintly palpable, with a dopplerable popliteal and a dopplerable dorsalis pedis, but his posterior tibial was completely absent. On the left side, he had a 2+ palpable pulse with a dopplerable popliteal and DP and PT as well. There was significantly delayed capillary refill on the right foot, and it was cool compared with the left. ABI measured in the ER was 0.27 on the right and 0.67 on the left. So we'll proceed with our diagnostic pictures. Obviously, this patient needed to be brought to the lab as soon as possible. Start off with an aortoiliac shot, which clearly revealed he's got the prior iliac stents, as was stated in his past medical history, but we have stent failure with fracture appearing on the right side. Also, you'll notice bilateral FEMPOP bypasses that appear to be closed. There's angiography down the right leg coming from the common femoral, and anybody can tell me what they don't see. We don't see the bypass, we don't see the SFA native, and we see just bridging collaterals coming off of the profunda. Now, I promised this was a delayed cine of below the knee, and essentially what this is going to eventually show is there's no flow below the knee. It's TIMI 0 to 1 at best with bridging collaterals, and you can almost imagine seeing a TP trunk here, but there's really nothing significant down there. Sorry. So as I stated, the right common iliac was widely patent. Stents noted extending from the mid portion of the external iliac down to the level of the right common femoral were noted, with 2 distinct areas within those stents revealing an in-stent restenosis as well as stent failure with a fracture. The right common femoral artery is widely patent and is post-surgical, with a closed SFA and FEMPOP bypass with noted collateral flow as I described. So the initial intervention, we decided to pursue going after that iliac, thinking the iliac was what pushed him over the edge to presenting into the emergency room. We placed a 6 French 45 centimeter destination sheath from the left common over to the right common femoral artery, and then we essentially unsheathed a 7.0 by 80 Armada compliant balloon in order to start with balloon angioplasty of the right external iliac. We ballooned the external iliac lesions at up to 8 atmospheres of pressure for a total of 1 minute. The balloon catheter was then removed, and we deployed an 8.0 by 59 millimeter Omnilink balloon expandable stent over the wire and across the two lesions at 10 atmospheres of pressure. The balloon was then removed, and an 035 2-row advantage wire was advanced to the level of the common fem. So here you see the balloon going up across the two lesions. So our flow post. The intervention continued. We took an 035 angled trailblazer and brought it down to the level of the common fem. And several attempts were made at passing the advantage wire into the native SFA, and they all failed. Even getting into subintimal territory, we just were not able to get in there, and it really almost appeared as if the ostium of the SFA was sewed closed when they did the bypass. However, the best news was the wire sailed down the FemPop bypass itself, tracked down, and were able to easily get through the distal cap of the CTO into the P1 segment of the popliteal artery. We then advanced the wire and held it within the right posterior tib. So this is our wire down through the CTO of the FemPop graft with slow flow on initial injection. The trailblazer was removed, and a 50 by 250 millimeter Armada compliant balloon was advanced over the wire and inflated in repeat fashion, extending from the popliteal artery back through the FemPop bypass to the level of the common femoral. 2 total inflations at 8 atmospheres of pressure for a minute. Following that, a repeat balloon angioplasty was performed utilizing a 60 by 100 at the level of the popliteal and up through the FemPop bypass. It's just one of the balloon inflations right there. And we start to see improved flow down the bypass graft. Following this, 50 by 60 impact Admiral DCB was advanced over the wire and inflated across the popliteal artery from the P3 back to the P1 segment for a total of 3 minutes at 8 atmospheres of pressure. An additional compliant balloon was inflated from the distal pop into the TP trunk and down the perineal artery for 1 minute. Following this, the Supera 50 by 80 self-expanding stent was released, extending from the P3 back to the P1 segment of the popliteal, and a 60 by 120 Supera was released essentially from the touchdown of the FemPop bypass at the P1 segment through the adductor canal into the mid portion of the FemPop bypass. Repeat angiography revealed complete resolution of stenosis with reestablishment of TIMI-3 flow through the bypass graft down to the level of the below-knee trifurcation with a 2-vessel runoff, including the anterior tib and perineal artery to the foot. These are our results. So this is post-balloon angioplasty. This is the initial stent placement at the bottom of your screen. And this is our runoff. Any questions?
Very challenging case, and I think well, much better than expected outcome here. Chris, any comment?
Yeah, I think obviously nice work, good outcome. There's a lot of good work, a little bit of luck there. Let me explain what I mean. I think that was a thrombotic occlusion acutely of a FemPop graft. I mean, clinically it makes sense. He had a sudden development. He had a cool foot. The external iliac didn't do that. The SFA was heavily calcified, and your wire flew down. So putting those 6, 7, 8 things in mind, that was a thrombotic occlusion of an old FemPop graft. So in some ways, one consideration would be: do you think about putting a lytic catheter down there and leaving it, and then coming back and maybe not having to do as much balloon and stenting, and maybe having less chance of distal embolization. I mean, beautiful result, and not a criticism, but it sure smells like an acute occlusion of a fem pop graft.
I would completely agree with your thinking, and we actually had this conversation in the lab. If I were able to go back to the original angiography at the level of the aortoiliac bifurcation, what you would note is both fem-pop bypass grafts were totally occluded. Okay, so my honest opinion was, in looking at both legs, okay, we get down to the common fem, both profundas are open. The difference between my right and left is the fact that we don't have iliac disease on the left, which is supplying more than enough flow through the profunda for whatever collaterals were present there. Because again, we're dealing with 15-year-old bypass grafts that have probably been closed for a while. Again, that was our intuition based on seeing both bypass grafts being down.
I mean, usually when you see a 15-year-old bypass, if it's chronically occluded, boy, it's pretty hard to wire and get catheters down. But that's
completely understood.
Beautiful, beautiful result.
Well, also on the interim angiogram, before you stented, there was at least 2 areas which were suspicious of thrombus. So I think, considering maybe a specific thrombus removal strategy, or at least this protection might have been a good idea. But I mean, lucky that you got out of it. Any further questions? Comments? Yours?
No, I think if you would have asked me to bet on this on the outcome of this case, I would have bet for distal embolization for sure. So I think sometimes you are lucky, but this was completely unexpected, the outcome for me. And I think I would have chosen a different approach, especially correlating the clinical presentation of the patient. I don't think this iliac stenosis is something that developed in such a short time.
Understood.
And that's why I think that the bypass went down relatively short time before that.
So maybe one question to the panelists. I mean, in that scenario where you have a occlusion of the native SFA and an occlusion of the bypass, I mean, in some cases you have the choice to go for one or the other. How do you make this decision?
Well, I think in this case, being a bypass of 50 years before, I think we have learned from the surgeons not to burn bridges for them by stenting anastomotic sites, but we also should teach, and I think we have taught the surgeons in the past not to suture the origin of the SFA in the same way. Yeah. And I think 15 years ago, it was a no-brainer for a surgeon. They just sutured the already occluded SFA, and I think that's the most important thing that makes me decide for one or the other.
All right. So,
I was just going to add, there's a nice paper for coronaries that says occluded vein grafts in coronary circulation, a temptation that ought to be resisted. And the reason is that the endothelium on vein grafts is living off of the oxygen going by. So once it occludes, all that endothelium is occluded and dies, and so it ends up becoming a PTFE graft. So whatever you do to this now, you just have to surveil it like a PTFE graft. It's going to fail fairly quickly, and it'll fail fairly abruptly, unfortunately.
All right. Well, thank you very much for presenting.